With the advancement in premium IOLs, our expectations are sky high. Small corneal surface lesions are often important as they can change the vital statistics of cornea. Failure to recognize or ignoring them may lead to wrong keratometry reading, wrong IOL power calculation, wrong IOL selection like toric or no toric, or wrong judgment of axis in toric IOL. This video will show some small corneal lesions, big problems for premium IOL surgeons. A 63-year-old lady presented with grade 3 NS cataract with best corrected visual acuity 20/60. She was advised toric IOL elsewhere. IOL power calculation showed plus 18 diopter and her K readings showed a cylinder of 1.9 at 10 degree. On examinations, few elevated dots on the cornea were noticed in the pupillary area just off center. Corneal topography showed distortion of Meyers with 5 diopter cylinder at 138 degree. Cataract surgery deferred and she was advised for epithelial debridement and BCL first. After 6 weeks, her corneal epithelium was absolutely normal. Corneal topography at that stage was regular with astigmatism of 0.2 cylinder. IOL master showed emmetropic IOL power plus 19.5 diopter with only 0.9 diopter cylinder. She underwent phaco with regular aspheric hydrophobic IOL implantation. Moral of the story: first surgeon missed the corneal lesion, and this was EBMD. What is EBMD? Epithelial basement membrane disease, or EBMD, is also known as map dot fingerprint or Cogan's microcystic dystrophy. Localized thickening epithelium due to reduplication of basement membrane. Patient may present with recurrent erosions. Diagnosis is difficult. Negative stain with fluorescein or sclerotic scatter are seen. If the patient presents with recurrent erosion, treatment is alcohol epithelial debridement. With diamond bar polishing. Then apply BCL for 3 to 4 weeks. To summarize, cornea reepithelized by 3 to 4 weeks, repeat topography and IOL power calculation, then plan for cataract surgery. Any premium IOL may be given. Always explain the recurrent nature of the disease and tear substitute for a long period of time. This is another 68-year-old lady who herself opted for cataract surgery with premium IOL. On examination, she had a paracentral nodular lesion. Corneal topographic Meyers were irregular and the cylinder was more than 4 diopter with flat cornea. Toric calculation suggested T9 series at 32 degree. She was diagnosed as SND with NS grade 3 and advised for surgery for corneal lesion first. SND or Salzmann nodular degeneration. What is it? It is typical bluish-grey nodules, single or multiple, often associated with chronic inflammation. They are elevated and located in mid-peripheral cornea, causing much distortion of K readings. Thus, cataract with SND is a unique challenge. Nodular resection or superficial keratectomy with diamond bar polishing is treatment of choice. On the topical or perivalvar block, with the help of forceps, the cleavage plane was identified. And then the nodule was resected with fine tooth forceps, just peeling off the diseased area. Diamond bar polishing to smoothen the corneal bed. At the end, a BCL was placed. Cornea reepithelized by 4 weeks. Corneal topography was regular with astigmatism of 2 diopter. Then a toric IOL was implanted in this patient. To summarize, management options for SND: prior topography and slit lamp photo, remove corneal nodules, diamond bar polishing, PTK with MMC may be necessary for associated subepithelial scarring. Sometimes it is difficult to determine whether the visual loss is due to corneal changes or due to lens opacity or both. Nodular resection will give the clue. Like EBMD, always repeat K readings and IOL power calculation after 4 weeks when the surface is regular. Multifocal IOL may not be a good option as cornea retains some irregularity and may reduce the contrast. Even a small pterygium with SND may cause more keratometric distortion. Prior surgery of both are essential to regularize the corneal surface before cataract surgery. In conclusion, before recommending cataract surgery, identify these small surface lesions like EBMD or SND and address them before IOL power calculation. Otherwise, there will be surprises with suboptimal visual outcomes. Slit lamp photography and topography are very useful tools to counsel the patient about these comorbidities and then appropriately set their visual expectations. Counsel about recurrent nature of these diseases and longer recovery compared to routine cataract surgeries. Thank you.